Welcome to the deep dive. Get comfortable, because today we're really getting into something huge, the complex world of pain.
And the search for better ways to manage it.
Exactly. We've got this stack of sources you sent over research papers, articles, notes on new drugs. It's all about pain relief, especially moving beyond opioids.
A topic that's, well, incredibly relevant, especially for anyone heading into clinical practice. Understanding pain, the tools we have, and the tools we need. It's fundamental.
Right. So our mission today, unpack these sources, pull out the key stuff, and give you a clear view connecting, the basic science to what you might actually see and use later on.
Think of it as a primer on a really critical, fast-moving area.
Because the need is urgent, and frankly, the scale of the pain problem itself is just enormous.
Absolutely enormous. The sources really hammer this home. We're talking, over 100 million Americans dealing with chronic pain.
That number's staggering. More than heart disease, cancer, and diabetes combined.
That's what one source indicates, yeah.
Yeah.
And the cost. You mentioned $500 billion a year in the U.S.?
$500 billion. Healthcare, lost wages, quality of life. It's a massive societal burden.
It really is. And inevitably, this brings us straight to the opioid crisis.
Yeah, the sources don't shy away from that. Even with some recent dips, the numbers are still devastating. One source mentioned maybe 48,000 deaths in a year.
And another put it even higher, maybe over 80,000 annual overdose deaths from opioids. Just tragic numbers.
And that underscores why they're so problematic, despite being powerful painkillers.
Exactly. Addiction is the big one, everyone knows. But there's also severe constipation, sedation, that dangerous respiratory depression.
Where breathing slows down,
Yeah.
potentially stops.
Right, intolerance builds up fast. So you need more and more for the same relief, which just increases the risks.
The sources even touched on the history, how we got here, with things like heroin being marketed as safer than morphine initially.
Yeah, a cautionary tale. And overuse can sometimes even worsen pain, paradoxically. Plus, withdrawal is just brutal.
So despite all that, they are still used sometimes.
For sure. For specific situations like severe acute pain after surgery, some cancer pain, certain nerve or vascular pain conditions, they have a place.
But the sources seem clear for chronic non-cancer pain.
Hmm.
The long-term evidence just isn't strong.
Precisely. Tolerance often makes them less effective over time anyway, while the risks remain or even increase. That's the dilemma.
Okay, so that's the problem. What about solutions? The need for non-addictive alternatives is obvious.
It's urgent. And the CDC guidance mentioned really pushes for using non-drug and non-opioid drug options first, whenever possible.
Especially for that subacute or chronic pain.
Right. They just don't carry the same heavy baggage.
Which leads us neatly into the new treatments highlighted in the sources. Let's talk about Journavex Suzregine.
Okay, Journavex, this one's significant. FDA approved recently first-in-class non-opioid for moderate to severe acute pain.
And its mechanism is different, right? It's not hitting opioid receptors.
Correct. It targets sodium channels, specifically voltage-gated sodium channels in the peripheral nervous system.
So for those of you studying physiology, this is acting out on the nerves before the signal really gets going towards the brain.
Exactly. Think of it like blocking the message right near the source, rather than trying to intercept it centrally like opioids do. It dampens that electrical signal transmission along the nerve fiber.
Interesting. A totally different angle. And the clinical trials. Sources mentioned phase 3.
Yeah, two big ones. Looked at post-surgical pain, abdominoplasty, and bunionectomy. Journavex showed a statistically significant edge over placebo in reducing pain.
Even when patients could take ibuprofen for breakthrough pain.
Right, suggesting it adds real benefit on top of standard NSAIDs.
And the FDA gave it all those special designations. Breakthrough, fast track, priority review.
Which really tells you how keen regulators are to get effective non-opioids out there.
Of course, there are side effects, listed itching, muscle spasms, a rise in CPK.
Ferritin phosphokinase, indicates some muscle stress, and rash. Also, important drug interactions to watch for, like strong CYP3A inhibitors. You'll learn all about those enzyme symptoms, and grapefruit.
The classic pharmacology warning. But Journavex isn't the only iron in the fire, right?
Not at all. The pipeline is actually quite active. One source, Delvinsight, estimated maybe over 20 companies working on 25-plus drugs just for chronic pain.
Wow. So lots of different strategies being tried.
Definitely. Things targeting cannabinoid receptors, different types of opioid-like molecules designed for safety, other novel mechanisms. It's not just sodium channels.
Okay, let's zoom in on another one mentioned. SBI 810 from Duke.
Right, SBI 810. This one has a really fascinating mechanism. It targets a different receptor, entirely neurotensin receptor 1, or NTSR1.
Found on sensory nerves and in the central nervous system, too.
Correct. And the way it activates this receptor uses a strategy called biased agonism.
Okay, biased agonism. Let's
Yeah.
break that down for, the students listening. What does that mean?
So think of a receptor like a light switch with multiple functions attached. A normal agonist flips the main switch and turns everything on. Biased agonism is like carefully flipping only one specific function switch linked to that receptor while leaving the others off. Ah, okay. So SPI 810 tries to activate the NTSR1 pathway linked to pain relief,
Specifically, the Bavarestin-2 pathway, according to the sources.
while avoiding other pathways linked to the unwanted side effects you get with opioids, like euphoria or addiction.
That's the goal. It's trying to be much more selective in the downstream signaling it triggers. Kind of like picking the therapeutic lock without setting off the side effect alarms.
Very cool concept. And the results in animal models sounded pretty good.
Yeah, in mice, it reportedly reduced pain effectively across different models, surgical pain, nerve injury, even fractures. They saw fewer visible signs of distress, like grimacing or guarding.
And crucially, what about the typical opioid side effects in these mice studies?
That's the really striking part. The sources say no constipation, no sedation, no memory issues, no signs of euphoria.
Any tolerance buildup.
Exactly. Repeated use didn't seem to require higher doses to maintain the pain relief in the mice tested. That could be a huge advantage if it translates to humans.
How did it stack up against other drugs in mice? It apparently did as well or better than aliceridine, which is a newer type of opioid in some tests, but with fewer distress signs. And it reportedly beat gabapentin for nerve pain without the sedation issues gabapentin can cause.
And it might even help opioids work better at lower doses.
That was another finding mentioned potential synergy, allowing lower opioid doses when used together in mice.
Still early, obviously, but definitely one to watch. Human trials planned, patents filed.
It represents that cutting edge of trying to design smarter, more targeted pain drugs based on a deeper understanding of the biology.
Which brings us to how we get that understanding. We need to talk about the research tools, specifically the animal models mentioned in the PMC source.
Absolutely fundamental. You can't really appreciate drug development without understanding how we study pain in the lab. So why animal models?
Well, the source says they've been critical for, over a century, right? For figuring out basic mechanisms.
And for modeling specific pain conditions, you can induce nerve injury or inflammation in ways you ethically can't in humans to study those specific pain types.
And the concept of face validity is important here.
Very important. It means the model should actually look like the human condition it's supposed to represent. The symptoms, the behaviors, the underlying pathology should mirror what you see in patients.
Makes sense. You want the model to be relevant.
And crucially, pain isn't monolithic. The source stresses this. Nerve pain is different from inflammatory pain, is different from bone pain. Good models need to reflect that specific type of pain because a drug might work for one, but not another. As a clinician, you'll constantly be asking, what kind of pain is this?
Okay, so you have the model. How do you measure the pain? Animals can't fill out a questionnaire.
Right. The PMC source outlines two main ways: reflexive tests and non-reflexive tests. Reflexive tests measure reactions to a specific stimulus: heat, cold, pressure.
Like poking with calibrated filaments of Onfray hairs. Or timing how fast they pull away from heat.
Exactly. These measure sensitivity, like thresholds. They're good for looking at hyperalgesia, that increased sensitivity common in pain states. Think of them as rough proxies for the quantitative sensory testing, the QST you might do in clinic.
Okay, so that's evoked reflexive pain. What about non-reflexive?
These try to capture more ongoing spontaneous pain behaviors or how pain affects overall function and maybe mood.
Like watching if an animal guards an injured paw, or licks it, or changes in how they walk.
Yes, things like paw guarding mirror how a person might protect an injured limb, or using automated gait analysis systems like Catwalk mentioned to see subtle changes in weight bearing.
And some tests even try to get at the unpleasantness, the emotional side.
That's where things like the place escape avoidance paradigm, or PEEP, come in. Does the animal learn to avoid a place where it experienced pain? This might reflect the aversive emotional quality of pain, maybe tapping into brain areas like the anterior cingulate cortex, which we know is involved in the unpleasantness of pain in humans, too.
So it's getting beyond just the ouch reflex.
Right. And also looking at things like Changes in overall activity. Does the animal run less on its wheel? That reflects the functional impairment common in chronic pain.
It sounds like you need a combination of these measures to get a full picture.
Absolutely.
Yeah.
That's the key takeaway from the source for translating this to humans. No single measure tells the whole story. A drug might blunt the reflex response, but not touch the spontaneous pain or the functional deficits.
Mhm.
You need multiple angles evoked, spontaneous, effective, functional, just like you assess multiple dimensions of pain in your patients.
So understanding these models and measures helps interpret the research behind drugs like Journavex and SBI 810.
Exactly. It helps you understand the preclinical evidence, its strengths, its limitations, and how it might translate or not translate to human clinical trials and eventually to your patients. It's that bench-to-bedside bridge.
It really connects the dots. Seeing how the fundamental science refining these models leads directly to testing these novel drug mechanisms.
And while the new drugs are exciting, we have to remember what the sources also stress. Especially for chronic pain, it's rarely just about a pill.
Right, the multidisciplinary approach, combining drugs with physical therapy, exercise, psychological support.
Yeah, those non-drug therapies are crucial, and as the CDC source notes, they avoid medication risks. But
But access and cost can be huge barriers for patients.
definitely, that's a real-world challenge you'll face, balancing the ideal treatment plan with what's actually feasible for your patient.
So looking ahead, the future involves better diagnosis of the type of pain, and then using a whole toolkit, new drugs like these, established ones, non-drug approaches in a really personalized way.
That seems to be the direction, understanding the options, their mechanisms, their pros and cons.
So to wrap up our deep dive, we've seen the sheer scale of the pain problem, the limitations and dangers of opioids driving the search for alternatives.
We looked at new mechanisms like peripheral sodium channel blockers with Journavex and targeted approaches like biased agonism with SBI 810.
And we explored the crucial role of animal models and why using diverse ways to measure pain in those models, reflexive, non-reflexive, functional, is so important for understanding how potential treatments might work in people.
It's a field full of complexity, but also, thankfully, a lot of ongoing research and innovation.
Definitely.
So maybe a final thought for you as you continue your training. We've talked about how pain isn't simple, how it has different types, different mechanisms. We've seen how research tries to model and measure these complexities. When you're faced with a patient in pain, how will this knowledge about heterogeneity, about needing to assess more than just a number, about these emerging targeted therapies actually shape how you think? How will you approach diagnosis? How will you weigh the benefits and risks of different options, integrating potentially new drugs alongside established therapies and non-drug approaches to really tailor the care? That's the challenge and the opportunity ahead.